Thank you, Marcus, for presenting very nicely how such very small virus like the parvovirus has caused 2 years ago a disaster in increasing levels due to the lockdown, and we had a lot of cases every center of follow-up and how to treat. Now we move to the next talk. In the program it's written toxo, but actually it was the working diagnosis. It means toxoplasmosis during pregnancy, and it will be presented today by Professor Mandelbrot, who's very famous on this field. Professor Mandelbrot is one of the experts worldwide on toxoplasmosis. He's working in University of Colombes in the antenatal diagnosis unit in Louis Murier Hospital in Colombes in France, and he will show us how to diagnose and the different aspects of toxoplasmosis in pregnancy. Please, Laurent, and don't forget to put questions in the chat because we'll have discussion at the end.
Hello, I thank the organizers for inviting me to give this talk on toxoplasmosis. I have no commercial interest to declare. The talk will be in 4 parts: some background, then an update on antiparasitic therapies for toxo in pregnancy, thirdly, prenatal diagnosis, and finally, management guidelines according to clinical situations. Congenital toxoplasmosis is a potentially devastating lifelong disease which can cause brain damage, fetopathies, and retinal lesions. However, the majority of infants with congenital toxoplasmosis are asymptomatic. The incidence of toxo has declined over the past decades in Europe, resulting in an 0.17 per thousand incidence of congenital infections in France in 2021. Much higher rates are observed in South America. The natural history of toxoplasmosis is well known. There are very few cases of congenital toxo due to preconceptional maternal infection, reinfection, or reactivation. Transmission risk increases with advancing gestational age, as you can see on the top graph. Among infants with congenital toxo, on the other hand, the risk of severe disease is related to infections in early pregnancy in the first or early second trimester, as shown in the middle graph. However, chorioretinitis can occur whatever the timing of fetal infection, as you can see on the bottom graph. The diagnosis of congenital toxoplasmosis differs radically according to whether or not serological screening is performed. In the absence of routine serologies, the diagnosis is either made after birth or prenatally because of ultrasound abnormalities. The so-called torch signs are generally nonspecific and may be lacking. Toxoplasmosis serologies have little help if positive, since IgM may persist for years, thus lacking specificity. Most countries do not screen for toxoplasmosis. If serological screening is performed, maternal seroconversion can be detected and prenatal diagnosis can be performed with amniocentesis. Now, this is what is done in France, which is one of the European countries with a prenatal toxo prevention program, along with Austria, Italy, Slovenia, and much of Germany and Spain. Screening is also recommended in Brazil and Colombia. The program includes routine serological testing, prevention, treatment, and prenatal diagnosis, as we will discuss later. Now, antiparasitic medications are used for 2 objectives. The first is to treat fetuses with congenital toxoplasmosis, to improve their outcome. They are also used as secondary prophylaxis to prevent mother-to-child transmission in case of maternal seroconversion. 2 different treatment regimens are commonly used. Spiromycin, which has few toxicities but has a weak antiparasitic activity. It is used only for prophylaxis. Pyrimethamine and sulfadiazine, on the other hand, is the most powerful anti-toxoplasmosis medication. It's used as therapy and as prophylaxis. Precautions are necessary because toxicities can occur. Because these are folate inhibitors, folinic acid supplementation is required, not folic acid, folinic acid, and this therapy is contraindicated in the first trimester of pregnancy because it could be teratogenic. There are alternative therapies with cotrimoxazole, but they have been less evaluated. Early therapy with pyrimethamine and sulfamides is the mainstay of postnatal management of congenital toxoplasmosis. The earlier the better, because when the parasite forms tissue cysts, antiparasitic drugs become ineffective to clear infection. There is some evidence from retrospective cohorts that starting antenatally improves outcome compared to starting postnatally. On the right is a European study showing that brain damage following a first trimester infection was reduced by a third with antenatal therapy. In the randomized controlled Toxogest trial, where therapy was initiated as prophylaxis, we observed that cerebral signs were significantly reduced when the mother received pyrimethamine sulfadiazine compared to spiramycin. There is also evidence that treating the mother as soon as possible after seroconversion reduces placental transmission. In observational studies, transmission was twice lower when therapy was started before 3 weeks versus 2 months after seroconversion. This makes sense since there may be a latency period between infection of the placenta with the parasite and transmission to the fetus, thus constituting a window of opportunity for prophylactic therapy. The epidemiological evidence is quite heterogeneous since most of the data is from retrospective studies, which either compared treatment versus no treatment or compared various treatments. In this review in prenatal diagnosis, I included only studies which took into account gestational age at the time of infection. This is fundamental since the risk of transmission strongly depends on the gestational age at the time of maternal infection. The only randomized controlled trial, Toxogest in France, mentioned earlier, compared pyrimethamine sulfadiazine with spiramycin as prophylaxis for maternal infections at 14 weeks or more. The transmission rate was lower in the pyrimethamine sulfadiazine group. However, the study lacked power to attain statistical significance. The figure on the right shows that the difference between the two groups in Toxogest was found at all gestational ages, albeit with overlapping confidence intervals. Now I'll turn to clinical management. Prenatal diagnosis can be performed simply with PCR. Using reference techniques, the specificity is 100%. There are a few false negatives, which should not be called false negatives because they're attributable to infections occurring later on during the pregnancy. Ultrasound signs are absent in the majority of cases of congenital toxoplasmosis. They are thus mostly useful to estimate the prognosis rather than for diagnosis. Now, several aspects are suggestive, and in particular, cerebral signs, which are ventricular dilatation and hyperechogenic foci or abscesses in more severe cases. Extracerebral signs are principally ascites and hepatomegaly or splenomegaly. In a contemporary multi-center study, which is the largest to date, we described 88 cases with ultrasound signs. Over 90% had cerebral signs alone or associated with extracerebral signs. Hyperechogenic foci and ventricular dilatation were frequently associated. Few fetuses had only extracerebral signs, and many of these were potentially independent of toxoplasmosis, such as a small for gestational age, oligohydramnios, or polyhydramnios. These should not be considered as signs per se of toxoplasmosis when they're isolated. On average, there were 3 ultrasound anomalies per fetus, with a wide range from 1 to 12 signs per fetus. The mean time from maternal infection to the first ultrasound signs was 8 weeks, with a range from 1.4 up to 24 weeks after infection. Ventricular dilatation involves the lateral ventricles symmetrically or asymmetrically, sometimes also involving the third ventricle. The mechanisms leading to hydrocephalus are obstructive or destructive. On the left is a postnatal series from the United States showing that the most common form was obstructive, principally aqueductal, but in many cases foraminal, and 1/4 were non-obstructive. On the right is a case from my center where rapidly increasing ventricular dilatation occurred with fetal death at 21 weeks. Pathology showed periventricular necrosis. Thus, in cases with obstructive hydrocephalus, the possibility of shunting can be offered, whereas in non-obstructive hydrocephalus, shunting will be totally ineffective. Isolated hyperechogenic foci are a typical finding in most cases, with several of them. Counting them is often challenging. Postnatally, they appear as intracranial calcifications. The neurological outcome is actually good when they're not associated with any other cerebral signs, especially hydrocephalus, although some of these children do go on to have some degree of developmental delay. There is clearly an increased risk of chorioretinitis, which has been shown in prospective cohort studies. MRI is usually not necessary for toxo. In this case of congenital toxoplasmosis acquired at 20 weeks, hyperechogenic foci appeared nearly 3 months later. One of these foci actually had a hypoechogenic component, which is shown by an arrow in A. This suggests that it's not a simple hyperechogenic focus, but an abscess. In this case, MRI showed that it was associated with diffuse polymicrogyria, thus confirming the poor prognosis. Here are a few postnatal images showing the correlation between ultrasound, CT scan, and MRI in a case with severe ventriculitis, cerebritis, and abscesses. This is a very unusual case report recently published where toxoplasmosis infection of the fetal brain led to microcephaly. Now let's turn to practical management. Here is a summary of the approach we use in France. Serological screening is performed in the first trimester, or if possible, preconceptionally. If the serology is positive for IgG and negative for IgM, the mother is immune, and there's no point in testing ever again. If the serology is negative, then primary prevention must be stressed, which is food hygiene, cooking meat thoroughly, washing fruits and raw vegetables, avoiding contact with cat litter and soil, and we perform monthly surveillance. Now, in case of primary toxoplasmosis infection, prophylaxis is offered. Before 14 weeks, spiromycin is used, and at 14 weeks or more, pyrimethamine and sulfadiazine. Then amniocentesis is offered. If PCR is negative, spiromycin is prescribed until delivery. Ultrasound is performed monthly. The child needs to be followed up postnatally to confirm that he's uninfected. If PCR is positive, pyrimethamine sulfadiazine is continued prenatally and postnatally. Ultrasound follow-up should be every 2 weeks, and in case of severe lesions, termination of pregnancy may be considered. In most cases, the child will be followed up and treated postnatally. When serological screening is performed, the clinical issues differ according to the timing of maternal infection, as we've seen. Preconceptional infection carries a negligible risk. First trimester infection will be at low risk of transmission, but can have severe consequences for the baby. And second or third trimester infection has a very high risk of transmission, but a low risk of brain lesions, not higher than in the general population. However, these infants may have eye lesions, which can be reduced by early preventive treatment. Now, when considering first trimester toxoplasmosis, the main practical issue is to interpret a first serology with presence of IgM and IgG. Since IgM can persist for years, we need to determine whether maternal infection occurred before pregnancy and reassure the patient, or in the first weeks. The first thing to do is to look for a prior positive test. If there's no prior test, then we'll check for avidity, but it's useful only if avidity is high, indicating that it's not a recent infection. Otherwise, a low or intermediate avidity is compatible with recent infection, but also with infection occurring many months or years ago. In those cases, we need to repeat testing comparatively 2 to 3 weeks later. If the titer of IgG increases significantly, then we can conclude that the mother was infected after conception. In those cases, prophylaxis with spiromycin and prenatal diagnosis should be offered. If the amniocentesis, which we'll then perform at 18 weeks, is negative, then we'll just continue spiromycin and follow up. If the PCR is positive, then the mother should be treated with pyrimethamine, sulfadiazine, and folinic acid, and ultrasound follow-up should be more frequent. Now, what are the prognostic factors in case of a positive prenatal diagnosis? The first is the timing of maternal infection. Since it fits in the third trimester, we can exclude brain damage. However, if it's in the first trimester, brain damage can occur or not occur. The second very important factor is ultrasound, since in case of ventricular dilatation or major ultrasound signs, the prognosis will be poor, and therefore careful follow-up is necessary, since, as I showed, the ultrasound signs can appear several weeks and even months after fetal infection. So those are the two very important elements to establish prognosis. There are other factors which are associated with outcome, but they're not useful in clinical practice. These are maternal immune suppression, which may increase the severity of toxoplasmosis. There's biology, the amount of parasite, and there's a parasite strain, which is important because South American strains in particular can be more virulent, but it's not a good prognostic indicator in and of itself. So the 2 points really to remember are the timing of infection and ultrasound signs. Here's a typical case from my center of ventriculomegaly appearing 1.5 months after maternal infection, associated with several hyperechogenic foci. 2 weeks later, the dilatation had increased and necrosis was clearly visible. This rapid increase in ventriculomegaly is something very typical of toxoplasmosis. These parents decided to have the baby, and brain damage was evident at birth. The child went on to be blind, deaf, and with severe neurodevelopmental delay. Second or third trimester toxoplasmosis is more straightforward, since we have a positive IgG and IgM following a previous negative serology. So it's clearly seroconversion that we see. In those cases, we should offer prophylactic treatment with pyrimethamine and sulfadiazine and folinic acid, and prenatal diagnosis with amniocentesis. And then, of course, ultrasound follow-up depending on the result of the amniocentesis. Finally, when maternal toxoplasmosis occurs very late in pregnancy, after 33 weeks, prophylactic treatment is clearly indicated to decrease the risk of chorioretinitis. That's always pyrimethamine and sulfadiazine. However, amniocentesis is still useful for prenatal and especially postnatal management, although the treatment will not be changed according to the result. In all cases, we'll continue pyrimethamine, sulfadiazine until delivery. In the absence of prenatal diagnosis, diagnosing toxoplasmosis in the infant usually requires several weeks or months based on serological investigations. So it's much better for the pediatrician to know beforehand if the baby's infected or presumed uninfected. And of course, if he's presumed uninfected, he will have to be followed up carefully to eliminate any false negative or infection after the date of the amniocentesis. There's still a number of research issues involved. One is to reduce the cost of testing. There are several medico-economic analyses that showed that avoiding even a small number of lifelong disability is cost-saving, but still it's an enormous cost to test a large proportion of seronegative women every month. Further clinical trials are necessary to confirm the efficacy of anti-parasitic drugs to prevent transmission and to develop new therapeutic strategies. Now, there are anti-parasitic drugs which are already used in people with toxoplasmosis outside of pregnancy and need to be better evaluated in pregnant women. These studies should be performed in settings where the burden of toxoplasmosis is the highest in the world, in other words, in South America. In summary, first of all, there's no vaccine for toxoplasmosis, but primary prevention reduces the risk of acquisition. Serological screening allows for timely therapy and prenatal diagnosis in case of maternal infection. In case of maternal seroconversion, secondary prevention should be offered with pyrimethamine, sulfadiazine, and folinic acid in the second or third trimester, or with spiramycin before 14 weeks. These patients should be managed in reference centers with prenatal diagnosis. Thank you. I'll be glad to answer your questions, and here are a few references for further reading.